Good evening, everyone. Thank you so much for taking the time to be here on your Friday night. My name is Nicole Villas, and I will be your moderator for the evening. I'm the mom of a 15-year-old boy with Dravet syndrome, which is a severe form of epilepsy, but aren't they all severe? And I volunteered for the Epilepsy Foundation for several years. We are so glad that you could make it to this educational event. It's the largest one of the year. This year, our Epilepsy Connect Symposium is presented by AZI. Thank you to our daily sponsor, Greenwich Biosciences, for supporting Friday sessions. Tonight, the title session is Raising a Child with Epilepsy, and it's presented by Zogenix. We will hold all questions until the end, but please feel free to enter them into the chat during the presentation, and I'll make note of them and make sure to ask Dr. Knupp after she finishes. And now I'd like to introduce our speaker for this evening. Dr. Kelly Knupp is an epileptologist and the interim chief of the neurology department at Children's Hospital, Colorado. Dr. Knupp serves as the chair of the Professional Advisory Board at the Epilepsy Foundation of Colorado. She has been involved with the foundation in many different capacities, including with the summer camps for more than 12 years, presenting educational talks, and all sorts of volunteer activities. She is truly an expert in raising a child with epilepsy. So it is my pleasure to turn the evening over to Dr. Knupp.
Thank you, Nicole. I just want to make sure, I kind of want to do a sound check and make sure everybody can hear me. Somebody let me know if you can't. Thank you so much for the Epilepsy Foundation for coordinating this series of talks. Thank you for inviting me to speak and giving me the opportunity to talk about raising a child with epilepsy. And thank you to all the participants for giving up your Friday night to listen to me talk about this. I do have a number of disclosures about grant funding and consulting. People who have reached out to talk to me about epilepsy because they think I know something about it. But I think the most important disclosure is that I'm not actually raising a child with epilepsy. And so I'm sure there are many experts in the audience who know more about this than I do. But I'm going to do my best to try and summarize what I've learned about this from my patients and guide people through this. The first thing I want to talk about is just really defining seizures and epilepsy. And I'm sure this is old hat to everybody on the call, but I just want to remind everybody that a seizure is a single event that's characterized by a clinical change in neurologic function and associated with a change on EEG. Whereas epilepsy is having more than one unprovoked seizure or a single seizure with EEG findings that suggest risk for more seizures. And epilepsy is so much more. Seizures come from the brain, and so there can be disruption of more than what happens with just a seizure. And I think this is really important as we think about raising a child with epilepsy, because while seizures themselves are scary, I think all these other things are what parents are concerned about the most. And obviously your brain is involved in behavior and cognition, your thinking, your ability to pay attention. ADHD is something we see commonly in children with epilepsy, learning difficulties, and other motor system issues. And so it's really important when we talk about epilepsy that we think more of the whole child and how the epilepsy may be impacting all of these other things as well. And I actually think that that instead of saying epilepsy, we should really talk about the epilepsies, because there really are many different types of epilepsy. And it's really important to know what kind of epilepsy your child has. It impacts how we choose medications, what associated symptoms we might look for, prognosis, and risk in the family. And this is just to name a few. I'm sure there are many other things that we could think about that having that diagnosis would be important for. We have a number of common childhood epilepsies that we talk about, and sort of the classic ones that we talk about are childhood absence epilepsy, juvenile absence epilepsy, self-limited epilepsy with central temporal spikes, which has a number of different names, used to be known as benign Rolandic epilepsy, juvenile myoclonic epilepsy, benign occipital epilepsy, and Panayotopoulos syndrome. But there are also a lot of what we call age-related epileptic encephalopathies. And these are the epilepsies where we also see significant change alterations in thinking associated with the epilepsy. And there are a number of these listed here, including Lennox-Gastaut syndrome, myoclonic astatic epilepsy, Dravet syndrome, West syndrome, Odahara syndrome. And we can see that these different epilepsy syndromes present at different ages throughout childhood. One of the other things that we have to contend with is that while these are syndromic diagnoses, we're increasingly finding genetic etiologies to a number of these epilepsies. And this really has changed significantly over the last 10 years. And I think this is a great pictorial of how much this has changed. And I don't know if you can see my cursor or not, but back in the 1990s, we really only knew about a handful of genes that were associated with epilepsy. And then there was kind of an increase around the year 2000. But in the last 10 years, this line in our diagnosis of genetic disorders really has turned into almost a straight line up. And we see this in our genetic testing. It used to be we would do single gene tests to look for different types of epilepsy. We were super excited when we had a panel that had 17 genes on it. Within a year, that turned into a panel of 40 genes. And now we're often sending out panels that can have up to 400 genes on them that are known to be associated with epilepsy. This is really helpful because it helps us get a more specific diagnosis for an individual child, which may actually significantly impact the medication choices and how we prognosticate for that child. But it does make it very confusing because it means there are lots of different types of epilepsies out there, some of which may sit under a single syndromic diagnosis. So when somebody has a diagnosis like Lennox-Gastaut syndrome, there's a whole collection of genes that may be associated with that. And this is something that we're going to have to contend with in the upcoming years as we describe these different epilepsies. But I think the most important thing as a parent is to try and know what type of epilepsy does your child have so that you can better understand what that is. I think it's also important to remember that your neurologist is your partner. If you don't think your neurologist is your partner, you should probably find a new one. And here where I practice at Children's Hospital, we have a number of neurologists who specialize in epilepsy. And it really is important that you find the right one to work with. When you meet with your neurologist, it's really important that you describe the events that you're seeing. This is much better than trying to classify them because sometimes what somebody is calling a focal seizure or an absence seizure may not actually be that seizure type. But if you can describe the event to us, then we get a much better understanding of what that is. When I first started practicing neurology, many parents would actually act out their children's seizures, which was very helpful. But even more helpful than that, now people send us videos, and that is really, really helpful. So if you're ever able to get a video of your child's seizure, then you know your neurologist is seeing exactly what you're seeing. And describing that seizure sometimes can be very difficult. And what I often will tell my patients is we could all stand around looking at the same painting and try to describe the same painting, but our descriptions would all be a little bit different. And that's where a video is really helpful because we know we really truly are all seeing the same thing. It's really helpful to bring a list of questions. A number of times in a clinic visit, families will apologize for having a list of questions. But I find that very helpful because then I know I've actually answered your questions, which is my job. And, I know that, sometimes even myself, whenever you think of things that you want to make sure you do, but if you haven't written it down, you sometimes forget that. And so writing down that list of questions can be really helpful and actually can help guide what is discussed in your child's visit for that day. I think it's also really important to be watchful for side effects of our medications. Our goal is always no seizures and no side effects. And so that's something that we really need to partner with because we're only seeing your child for a very small period of time in the clinic visit. And so you need to describe these things to us. But I also think that we have to keep in mind that we don't want to let perfection be the enemy of the good. And so, while our goal is no seizures and no side effects, sometimes that's not reasonably attainable. And just like other things in life, we may have to find a place for compromise. And so it's really important to keep that in mind as well as you're working with your neurologist. I think it's really important as a parent to know about seizure triggers. There are numbers of seizure triggers out there, and they're usually very individualized for each individual patient or child. But things that are more common are illness, sleep deprivation, stress, fatigue, heat, or changes in temperature. We do often see sometimes very unusual triggers out there. So it's important to kind of keep track of those so that you can identify what might be a trigger for your particular child. I think it's always important to try to minimize triggers, but sometimes you can't completely eliminate it. For example, illness is not something that we can completely eliminate, but we certainly can make efforts to decrease illness or at least be wary around times when we see illness. And I think it's important to be practical about some of these things, to try and find a balance in living, a fairly typical life as much as you're able to, but avoid triggers as best you can. I do want to talk a little bit about illness, because lots of other issues come up around this, not just as a seizure trigger. One of the things that we should think about when a child has an illness is if a new medication is going to be described, are there any drug interactions? And I think it's really important to ask both the provider and the pharmacist about those interactions. This is a question that can't be asked often enough to potentially avoid something that could be a problem. If there is an interaction, it may not be avoidable, but at least you're then aware of it, so that you can help watch for it or do something to minimize that interaction. The neurologist office can also be asked, so it's not uncommon that medication is prescribed. Somebody's spoken to their pediatrician about it, and they've spoken to their pharmacist about it, and then they call in and speak to us about it. And we're always happy to answer those questions. Illness and fever are common provokers of seizures, and so it's important to be prepared for that. So, if illness is going through your family, that's a really good time to double check and make sure that your rescue medicines are available and not out of date. Perhaps remind yourself how to use the rescue medicines. So always important to be prepared in that situation. One of the other big issues that comes up is vomiting. The vast majority of our medications are taken orally, and kids vomit sometimes. And so it's important to know what to do around that. In general, we recommend redosing the medications if vomiting happens within 30 minutes of medication administration. So if you gave the medicine at 7 a.m. and then there was vomiting at 7:15, we would recommend just give a whole nother dose of that medication. If it's more than 30 minutes, we're a little bit more in a gray area because it's likely that some of that medication has already started to be absorbed. But if you see a whole pill, then certainly it would be very reasonable to think about redosing the medication. If you're not able to take medications because of frequent vomiting, we do recommend that you try small sips of water or Gatorade. And when that's tolerated, give medications one at a time, about 30 minutes apart, so that you can slowly get that medication in and hopefully avoid provoking more vomiting by having large volumes in the stomach. Sometimes we actually do need to send people to the emergency room to receive IV medications. Not all medications are available in an IV form, but often what we can do around that is use an alternative medication to get everybody through the crisis. Seizure safety is something that's really important. And one of my rules of thumb when we think about seizure safety is we always want to keep safety at the forefront, but it's also difficult to be a normal adult if you haven't had a normal childhood. And as a parent myself, I certainly understand the want and the desire to wrap your children up in bubble wrap and keep them safe. But we do need to make sure that we allow children as much as possible to have a normal childhood. And I fully recognize that sometimes this isn't always possible, but we can try to use this as a guide and try to be a little bit creative about how to create those typical childhood experiences and environment. So perhaps, a child wants to go on a sleepover, but sleep deprivation is something that provokes their seizures. So how can we make that change that sleepover a little bit to make it safer? Sometimes it's actually having the sleepover at your house instead of having it at somebody else's house, because perhaps the other family is a little frightened at the idea of having a seizure, or perhaps it's a family you're not willing to talk to about the possibilities of seizures during the sleepover. The other mechanism that we sometimes will recommend is making sure that the child takes a nap before the sleepover and after the sleepover to ensure that they're not overly sleep deprived. One of my patients pointed out that sleepovers aren't really sleepovers, they're more stayovers. And so lack of sleep is something that's pretty common with that. For the most part, we generally do allow children to ride a bike. That will obviously depend on the type of seizures and the seizure frequency. We do recommend that everybody wear a helmet when they're riding the bike and stay away from busy streets. Water is something that deserves a little bit more attention because water can be very dangerous when somebody has a seizure. Excuse me for a second here. Um, so a shower is generally preferred over a bath. And the reason for this is that if somebody were to have a seizure in the bathtub, it would be very easy to be submerged in the bath, and that could actually cause some additional risk to having a seizure. And so a shower is generally preferred in that situation. If bathing really is what needs to happen for a child, we do recommend supervision. For younger children, we would recommend that somebody's at the side of the bathtub. For somebody who's having very frequent seizures, we would want to be particularly cautious about this because we don't want to risk having a seizure while you're actually in the bathtub. For older children who really prefer to take a bath, but really would like to preserve a little privacy, what I will often recommend to families is that the parent is outside the bathroom and is able to talk to their child while they're in the bath. I also recommend that the bathroom door be left unlocked, but everybody has pretty strict bathroom door rules that you have to knock before you enter to preserve some of the privacy for the child. The other thing that I would check is how your tub, how the drain cover works in your tub. A number of tubs have drain covers that actually sort of drop down in place. And if that's the situation, even if somebody's taking a shower, if they were to slip and fall, or if they were to have a seizure in the shower and fall on top of that drain and close it, the bathtub would start to fill with water, and that actually could be a dangerous situation. And so we would recommend taking that out and using a different type of drain cover. We do recommend supervision at the pool. There's great data out there that pools with a lifeguard are much safer than pools without a lifeguard. And so particularly for a child with epilepsy, we would recommend that there's a lifeguard at the pool. I also recommend to families that they designate an adult to watch their children at the pool. Most lifeguards are teenagers, and they are doing their job the best that they can, but they don't know the early signs of your child's seizure. And so there's going to be a little bit of a delay before they recognize that something's happening in the pool. Whereas a parent, you generally know when your child, you know the earliest signs of when your child is about to have a seizure and would be able to quickly recognize that and provide assistance. One of the other questions comes up is what to tell your child. And so, the biggest rule of thumb here is to be honest. Use words that they can understand. When your child asks a question, make sure you know what they're asking before you answer. Sometimes they may ask you a question and you may go into, a full-blown complicated answer, and it may be that they really were asking something that was far simpler and you've overwhelmed them. If they're asking a question that you don't know the answer to, seek help. And, that's what your neurologist and your neurologist staff is there to help you with. And so it's not uncommon that children, as they get older, will sometimes come with their own set of questions. And we'd like to give them every opportunity to answer those questions. Remember, the goal is for your child to trust you to have the answers. This is very different than during my childhood. Our children have access to the internet. And so if we don't give them the answers that they're looking for, they will actually go seek them yourselves. And we really want to make sure that children are talking to their parents about these things. And so that makes it particularly important to be honest. And remember, there is a point when it is certainly age and developmentally appropriate for you not to have all the answers anymore. But until then, we want your children to trust that you actually do have the right answers for them. What do you tell their siblings? It really is the same approach as talking to your child. You need to be honest. You need to answer their questions. Make sure you understand what their question is as you're answering it so that you don't overwhelm them. There are a couple of caveats for siblings. People who have epilepsy don't always see or remember their seizures. Now, they may see that video that you show them, and I see even young children don't really like to look at those videos of themselves having a seizure. but the siblings actually see the seizures. So their fear may actually be even greater than their sibling who has epilepsy. And so it's really important to acknowledge that and to, and be honest with them about how you feel. The truth is, all of us feel a little frightened when we see seizures. I see seizures day in and day out, and it still makes my heart rate go up, and I feel a little panicky every single time I see a seizure, and it's not my child. So I know that feeling must be far worse for all of the parents. Beware of these feelings of fear and helplessness, particularly when a seizure is happening. Siblings oftentimes tell us that they really just want to help. And, just as parents, that you may feel helpless, so does the sibling. And so it may be really important to give them a job, particularly if your child has big seizures, long seizures, or seizures that need intervention. And sometimes it's as simple as waiting at the door for the ambulance. But talk with your child and figure out what it is that they're comfortable with, because that really does help them feel a little bit less helpless in the situation. For some of our older siblings, it really may be helpful for them to have a CPR class or seizure safety classes. This can be really empowering for a frightened child to feel that they actually can intervene in a helpful way when these situations occur. Almost 2/3 of siblings feel worried and scared. This is actually great data that was collected by Laura Bailey and has recently been published. As parents, we often underestimate the amount of sadness and anxiety that our children are feeling. Siblings reported wanting more information about epilepsy, how to help, but they were hesitant to ask their parents, not because they didn't think that their parents didn't have the answers, because they didn't want to do anything that caused more stress for their parents. And so it's really important to keep those lines of communication open so that they know it's okay to talk to you about these things, and that it's okay to feel that sadness and anxiety, that you feel it also. Most siblings, approaching about 75% of siblings, reported positive aspects of having a sibling with epilepsy. And I think that's really important as well, and something really important to identify with siblings. And more than 50% of siblings who were asked plan to care for their sibling into adulthood. Now, these were siblings of children who had epileptic encephalopathies. So these were children who were impacted not just by seizures, but also by cognitive and behavioral issues. But I think this is really striking that these siblings really do want to help, and keep that in mind. Through that same data, there were some suggestions of ways to cope with a sibling's condition. And these actually do vary a little bit by age, but important to keep in mind. And I would also keep in mind that every sibling is a little bit different. And so it's important to kind of work out with them what it is that would be helpful to them. Some of the siblings really did want special outings with their parents and just a little bit of special time. Sometimes it was a fun game, app, or video that would help them when they're feeling stressed. Having more information about their siblings' epilepsy, spending more time with their friends, spending more time with other siblings of kids with epilepsy. It's really important for children to feel like they're not the only one, and that's something that can be really helpful. And learning new ways to help with stress, worry, and sadness. So all of these are ideas that the siblings thought might be helpful to them. And so a good thing to keep in mind as a parent. One of the other challenges as a parent is what to tell the school. When I started practicing neurology and seeing patients with epilepsy, many parents actually wouldn't tell the school that their child had epilepsy because they were fearful of their children being treated differently. In this day and age, because we do encourage seizure action plans at school, that is often a very good avenue to let the school know what's happening. And, the reality is, in a non-pandemic time, our children are often spending, 6 hours a day, 5 days a week at school. So they actually spend more wake hours at school than they do at home. And we wouldn't want to have a child have a seizure at school and not have people equipped on how to help them. I often do encourage children to tell their friends. I think it really depends on personality. Sometimes it's a handful of close friends, and sometimes it's all of their friends. But I think it is helpful to tell their friends, particularly if they're likely to have a seizure in front of their friends. That way their friends are not frightened when it happens. And the feedback I hear from kids is that their friends were really thankful that they knew that they had seizures and tried to do everything that they could to help them. Um, I do think that if seizures are likely to happen in the school setting, it may be helpful to educate the class ahead of time. And I think, again, you have to use your child's personality and approach to this as a guide. I certainly have a number of patients who at the beginning of every school year put together a PowerPoint and they talk to their class about their epilepsy and their medical diagnosis and share their story. And then I have other kids who really do not want to stand in front of the class to do something like that. But there are ways to provide that education to the classroom without pointing out that so-and-so has epilepsy and is a little bit different. And the best way to do that is to talk to the teacher about providing education as part of their health curriculum without identifying the student. But I do recommend doing that earlier in the school year. So not something I would put in March in the curriculum, something to put in the curriculum earlier in the year. And that may create a safe environment for the child to actually decide whether they want to share their diagnosis or not. And the Epilepsy Foundation can be helpful with this as well. I get a number of questions from parents about travel. I actually think it is really important to have family vacations and travel to those things that we all need to, although perhaps not this month in the current pandemic. I think the most important thing for the child with epilepsy is to avoid fatigue as much as possible. Make sure you take all of your medication with you, including your rescue medicine. You may want to create reminders for taking your medication while you're on vacation. Whenever we have schedule changes, it's when we're most likely to miss medications. And so that can be really helpful to set an alarm on your phone or your watch to make sure that you don't miss any medications. Make sure you have a plan for time zone changes. I think this is greatest when we see intercontinental travel. And usually what we will recommend is giving medication at the usual intervals, not at the usual times. And this can get particularly tricky if you're changing, time zones that's 10 or 12 hours. Otherwise, you may inadvertently miss a dose of medications while you're traveling. So something to keep in mind and make sure you have a plan ahead of time. I think we also need to make sure we acknowledge the impact on the entire family of having a child with epilepsy. We certainly know that this creates high stress in caregivers, and there's data out there that this can lead to deterioration of relationships, fear, uncertainty, sleep problems. Many families report that they feel as though they go through the grieving process. Things to avoid are sleep deprivation. We can see an impact on mental health, financial burden, and depression. So a number of studies have actually shown this impact on the family. And there are other impacts that have been identified as well, such as the physical impact. As kids get bigger, particularly if they're not walking well, that can be a challenge on the caregiver's physical functioning, and particularly with seizure care. Holding a 2-year-old who's having a seizure is very different than holding a 16-year-old who has a seizure. There's impact on social functioning with decreased recreational activity, less time due to increased care, as well as the emotional impacts that I've already mentioned from the other studies: anxiety, stress, less sleep, depression. There's an impact on siblings with less time, more caring, less time spent with siblings, but we also see some positive things there. Siblings are often reported as more caring and more empathetic. They're also more likely to go into health fields. And so there actually can be some good impacts on the family. There certainly are financial impacts that can't be ignored: the cost of equipment, medication, and respite care. As mentioned, there's impact on marriage and relationships, although 74% of people in Pat Gibson's work reported feeling closer together. And so there are some positive things to look here on family impacts. Pat Gibson, when she asked about caregiver concerns, she asked, what is the worst thing about the epilepsy experience? And top of that list was the fear of the unknown. What's next? Side effects of medication were a pretty close second: social isolation, feeling of helplessness, guilt, loss of the child they knew, and then other aspects. So these certainly are real things. I think it's hard to hear these, but I think it's important to acknowledge these because it creates an environment where you can actually talk about some of these things, which I think can only be helpful. This is some work that was actually done here at Children's Hospital Colorado, looking at the Dravet population and looking at time and difficulty of tasks. And I think I put this in here not to make life seem difficult, but really to just acknowledge the things that you are finding that take up your time and difficulty are really very real. And so the red bars are the things that take a moderate amount of time, and the blue bars was the amount of difficulty. And those things aren't always the same thing. So providing transportation provides a lot, takes up a lot of time, but it's not all that difficult. Medical and nursing treatments, families also reported took up a moderate amount of time, but were not difficult. I apologize. I thought I had turned my phone on silence. But there are other things that arranging for care really can be difficult and, also require amount of time. So these things are very real and impact daily functioning. So what can we do about this? Well, I do think it's important to take care of yourself. If you are not taking care of yourself as a parent, it makes it really difficult to take care of your child. And I know there are no perfect answers to this. And, I'm certainly busy as well, and oftentimes get reminded to take care of myself. And sometimes, as adults, particularly as parents, we put ourselves at the bottom of the list. But here's some ideas to help out with that. When people offer to help, I recommend that you take it. I would recommend that you be specific about what you need. Sometimes when people offer help, they're offering help that isn't really all that helpful. And so I think it's really important to have that dialogue and maybe offer them some options. But remember, those people around you who are offering to help, they're feeling helpless also. And sometimes it is really important to give them something to do. Make sure that you're all getting sleep. I talked to a number of families about this, and I think over time, people do figure out ways to make sure that they're getting sleep, whether it's taking shifts or, taking different nights. But, good sleep helps you to have a good day the next day. And so sleep is incredibly important. Make sure you give yourself a break. You cannot be perfect all the time. And, it's really important that you give yourself a break with that. And also take time to relax a little bit. It's important that you refresh and rejuvenate yourself so that you can go back in to take care of your child, particularly when things are getting difficult. If people aren't offering to help, reach out for help. Oftentimes people don't offer help because they don't know what to do. So you would be surprised if when you reach out for help, how often people really are willing to step in and do that for you. And if you're a person who needs to do something, do it. There's lots of opportunities to help the epilepsy community through the Epilepsy Foundation, through family organizations that are disease specific. The impact of these organizations, I cannot emphasize the importance of this. I think family organizations come in, several different flavors, and you can find something out there that suits your needs. But I see family organizations who help out incredibly by supporting other families, some that raise research dollars, which are leading to impacting research within the epilepsy community. So there's lots of opportunities out there to do that. And so if this is the type of person you are, I would really encourage you to make some time to do that. I think, it oftentimes does feel good to give back a little bit and also to broaden your community and realize that you're not in this all by yourself.
I think that's good. Dr. Knupp, thank you so much for sharing all of that information with us. I love that you are such a brilliant epileptologist, and yet you are still able to connect to the human side. It's really quite impressive. One thing I just wanted to add, when you were talking about travel, I don't know if parents know this, but any medications you bring with you on travel should go in your carry-on. They shouldn't go in any stored luggage. And if you have a lot of medications and equipment and you put it all in one carry-on, it doesn't count towards your carry-on limit. So know that. Don't feel like you're choosing between meds and whatever you need for, your one night stay. We did have several questions. I am going to share our sponsor screen again, because we are so grateful to the sponsors. We are so grateful for ASI and Greenwich Biosciences and Zogenix for sponsoring this. There we go. Okay, so we're going to share our sponsor screen while we do our question and answer. There were several questions and answers that came in. One of them, the first one was, during your talk about vomiting, the parent wanted to know if you've given liquid meds, does the time frame change on that since they're maybe absorbed a little bit faster, or does that still fall into the 30-minute rule?
we still generally recommend 30 minutes because oftentimes when somebody is vomiting and their stomach is upset, the gastric emptying has slowed down, and so the absorption rate has slowed down. So we would still recommend the 30 minutes to redose. That's a great question.
Okay, great. And then there was another question, and this comes from another parent. It says, Dr. Knupp, during camp and Ask the Doc session, a few of the young kids stated that other kids made fun of them at school for having a seizure. This has stuck with me since we attended camp. What is your advice on what to tell young kids and parents on how to deal with that?
Oh, and that's such a terrible thing. My hope is that with providing education to the other children, that they understand that this is something that kids don't have control over when it happens, and that it can be scary, that would help with that. I really suspect that, and I'm going to assume good in everybody. I suspect that the response for other children doing that is that they really don't understand it, and that they probably are scared themselves, and making fun of the child is a coping mechanism. So I think the more that we can address that fear in education, and really let people know, let children know that this is something that they don't have control over any more than they have control over some of their bodily functions, that would be helpful in that. And I certainly would hope that if this is coming up, that the teachers and the parents are stepping in as well to model appropriate behavior around this and to address the issue.
Great. We have another question, and this question is getting at rescue medications. Which seizure medication do you recommend for patients at school? Which is more effective in getting fast results without being too invasive?
So more and more often, we are recommending intranasal, so administered through the nose, rescue medicine, as opposed to rectal medication. Here in Colorado, we've been using intranasal midazolam, which we make out of the IV formulation of midazolam. There are actually two new products that are available on the market, intranasal diazepam and intranasal midazolam, that come in something that's a little easier to administer than what we were creating. So as much as possible, we recommend that. We do have some children who really do need to use rectal rescue medications, and oftentimes what we will recommend is, particularly if it needs to be given within 5 minutes of the onset of the seizure, that should be enough time to clear the classroom to maintain the privacy of the patient who's receiving that medication. Sometimes for particular seizures, we are able to use oral administration. And for some of our patients who may have feeding tubes, we can use that as a way to administer medications as well. So there are lots of things that we can use to try to preserve that privacy in that situation.
Great. So we have another couple questions more aimed towards the teenage population. How does puberty impact my child's seizures, if at all?
Yeah, so puberty is always tricky, and something, as parents of typical children, we're afraid of our kids going through puberty to begin with, and then to have seizures on top of that can be a challenge. In general, we see more issues with girls than with boys, but it's not always perfect. The issue that we see with girls is that estrogen, which is the main female hormone, tends to provoke seizures, whereas progesterone tends to prevent seizures, and testosterone tends to prevent seizures. So particularly for girls going through puberty, we always worry what will happen, but it's really difficult for us to predict. And what I generally say is it's sort of the rule of thirds. We see a third where it doesn't really make a difference one way or the other. We do have some epilepsies that we know get better as kids enter into puberty. So some of our classic childhood epilepsies, like childhood absence epilepsy, gets better as kids go through puberty. And then we see a third where things are not better or worse, they're just different. And usually what that looks like is cycling of seizures with the menstrual cycle. Which actually can be a blessing in disguise sometimes, because it may open up some other avenues for treatment or make seizures a little more predictable, allowing us to do some unusual things with medications. And then we have that group of patients where seizures just get worse as we go through puberty. And we also often will try to use hormone manipulation in that setting, because we usually attribute that to hormones, and we'll try that as an avenue for treating seizures.
Great. And then the next one on that, which was asked twice actually, is what are the rules in Colorado for teenagers driving?
Great question. Colorado is not a physician reporting state. So there are a handful of states in the country where physicians are mandated to report people with epilepsy, and Colorado is not one of those. But you do have to self-report when you go to the DMV. So there's a form that needs to be completed at the DMV. I haven't checked recently, but up until recently, it wasn't online at the DMV. You had to actually go in person to get it. And so in our office, we always try to keep the most up-to-date form so that we can help you fill that out. We generally recommend that people be seizure-free anywhere between 6 months to a year before they start driving. Colorado doesn't actually mandate the seizure-free time period, but you do have to have your physician sign a form saying that it's okay for you to drive. There are some caveats with that. So on that form, it'll ask about last seizure and time of seizure, duration of seizure freedom. Sometimes we will have patients who are still having seizures, but for 10 years, their seizures have been exclusively during sleep. And so for that patient, we may say, okay, you can't drive when you're sleeping because that would be dangerous because you fell asleep and you might have a seizure. So sometimes we come across these unusual caveats where we'll make that argument to the DMV for you. I do highly recommend that people fill out the DMV form. I know that it seems like it would be really easy if they're asking to just not be honest and not tell them about it and not have to fill out the paperwork. But we definitely have seen times when insurance has identified that you didn't fill out the appropriate paperwork and has denied coverage in that situation. And truthfully, for a teenage driver, they're more likely to get in an accident because they're reckless and don't have the experience rather than having a seizure. And so we want to make sure that we do everything to ensure that your insurance won't be a problem.
Great. And then 2 questions on sleep. The first one is, do you generally recommend any sort of sleep aid to combat the effects of medications or the epilepsy itself? And if so, what?
I think that varies from patient to patient. So a number of our medications are sedating. So sometimes we will actually switch dosing of medications to maybe give a little bit more at bedtime to help with sleep through the night. But we certainly have a number of patients who just don't sleep very well, which may be because of an alerting medication. We do have a handful of medications that are more alerting than others, or because of their underlying disorder, or because of seizures at night. And so in that situation, we may actually talk about other strategies to help with sleep. We usually try to start with behavioral strategies and then move on to medications. And it would really depend on the patient. So we may use things like melatonin, clonidine. Sometimes we actually do need to move on to other sedating medications like trazodone or Seroquel to help with sleep, but we try to avoid that as much as we can. We actually do have a sleep specialist who is a neurologist at Children's Hospital. And so that is often somebody that we turn to these days if we're having significant sleep issues.
Okay, and then the second question on sleep is, do you generally recommend that patients are monitored while they're sleeping, whether they have a specific syndrome or whether it's typical epilepsy or whether they have infrequent seizures? And if so, what do you recommend parents use?
Yeah, so I do recommend monitoring for patients who are having ongoing seizures. We know that monitoring, our data suggests that monitoring decreases the risk of SUDEP. Having somebody present when you have a seizure decreases your risk of having SUDEP, sudden unexplained death in epilepsy patients. So I generally encourage families to think about monitoring. And sometimes it's as simple as having a baby monitor so that you can hear what's happening. There are other monitors available on the market, things like the SAMI monitor or the MFIT monitor or the Embrace watch. A number of these have not been FDA approved for this purpose. And we definitely hear of failures with all types of monitoring. And I think it's really important to keep in mind that everybody's seizures look a little bit different, and it's hard to have a monitor that's going to be perfect for every single type of seizure. So I generally will talk to families about all of the different types of monitoring that I'm aware of. And then I will really encourage them to reach out to other families who may have similar seizure types to find out what has worked best for them.
Great. And then there are a couple of questions on medication administration. So one is, at what point do you think it's appropriate to start having the child manage taking their medications on their own and having the parent step back a bit? So that's the first question.
Why don't I address that before we go on to the next one? Otherwise I'll forget. So I think that I think that age is probably different for every child. I think there are some children who have intellectual impairment who will never be able to manage their own medication management. But I think for the typical child, definitely around 12 or 13 is when we should, if we haven't started talking about it, should start talking about that. And I think there are a number of strategies that can help. I do think we have to recognize that there are going to be mistakes. We make mistakes ourselves, and as a new skill for these young teenagers to be developing, they're going to make mistakes. But one of the things that can be really helpful is using a pill box. I think what's particularly helpful about the pill box is the kids can actually fill the pill box themselves, and parents can come back and double check it later. And I think this is a good way for them to learn the name of their medication and the dosing of their medication and how they should be taking their medication. I think the other benefit of the pill box is it can prevent some nagging. So if you're just taking your pill out of the bottle, the only way for the parent to know that their child has taken the medication, unless they're standing there watching them, is to nag them to say, did you take it? Did you take it? Did you take it? Which really, you have so many other things to argue about with your adolescent that it would be nice if we could take something out of that. And so the pill box is a way that you can allow your child to independently try to take their medication. And then 30 or 40 minutes later, you can simply check the pill box and see whether they did it or not. And that might be an appropriate time to nag them because they didn't take it, but you at least have given them their opportunity to do that. The other strategy that I recommend to kids as they're learning to do this is to try to link taking their medication with something they do every day. So if every morning they get a glass of orange juice out of the refrigerator, keep your pill box in the refrigerator so that when you grab the orange juice, you can grab your pill box and take it. And at night, if you brush your teeth every night, put the pill box by your toothbrush so that when you go to brush your teeth, you know that you need to take your medication at the same time. So linking it with other habits that are already existing can be super helpful as well.
And then the last question, and it's with medication again, and I think this is our last question of the evening before we close up, is if you forget a dose and you've forgotten it for more than 5 hours past when you should have taken it, do you recommend skipping that dose, or do you recommend taking the dose and continuing on as normal?
Yeah, so I generally recommend taking the dose unless it's time for your next dose. And then in that situation, you would skip it. So, so if it's 5 hours later and you take your medicine twice a day, I would take your dose at, that early afternoon hour and then take your dose that night. But if you're going to take your evening dose and you realize, I forgot my morning dose, then I would just skip the morning dose.
Okay, great. I'm not seeing any other questions from the audience, but if you do find that you forgot to ask something or you were uncomfortable asking in public, please feel free to reach out to Wendy Kogel. She is the care manager at the Epilepsy Foundation. Her email is caremanager, CAREMANAGER, at epilepsycolorado.org. And she's fantastic. And if she doesn't know the answer, she can connect you with the person that does. I want to thank our sponsors once again, ASI, Greenwich Biosciences, and Zogenix for making this possible. And I want to thank the Epilepsy Foundation as well. If you haven't been to any of their presentations earlier in the week, please go back and look at them. They've been fantastic. They will be available on the Epilepsy Foundation's YouTube channel sometime in the coming weeks as the volunteers and staff get those all collated and up on the YouTube channel. Please reach out to EFCO with any questions you have. You're always welcome to reach out to me as well. Epilepsy Foundation can connect you with parents that are going through the same thing that you are, if you just need to talk to another parent. Dr. Knupp, thank you again for your expertise. You always do such a wonderful job of bringing the human side to epilepsy and letting the parents know that this is a hard journey and that there are bright spots and there are low spots and there are tips and tricks that they can manage to get them through. So thank you to everyone. And with that, we will conclude our evening.